And good afternoon, everyone. I'm Dr. Williams, Chair of Medicine, and welcome to Research Grand Rounds. Wonderful to see everyone here and so many people online as well. And it's my pleasure this afternoon to introduce our Research Grand Round speaker, Dr. Leah Jean Siskind. She is a professor in the Division of Medical Oncology and Hematology at the Brown Cancer Center here at the University of Louisville. She hails originally from the University of Maryland in College Park, where she did her undergraduate, Ph.D, postdoctoral fellowship. She then moved on to do another postdoc at University of South Carolina, where she worked her way all the way up to assistant professor before being recruited here in 2013 as an associate professor. And consistent with that, she was ultimately promoted in 2020 to full professor here with tenure. And when you look at her CV, pretty impressive. A lot of honors, a lot of awards, a lot of grant funding, and really key publications. And so really proud to have you here in our department and to learn from you today about Cisplatin-Induced and nephrotoxicity, models, mechanisms, and comorbidities. Thank you, Dr. Siskind.
So first, I'm going to do a shameless plug. This group, Swim Across America, has raised $10 million for basic cancer research, and this is the very first.
100 million.
Oh, 100 million. Sorry, the big. This is the very first year they're putting on an event in Louisville on September 14th. And so if you want to take a picture of this, this will take you a link to the Brown Cancer Center research team that we will be swimming. And so we're trying to make sure we raise enough dollars that we'll get them back here next year to do this event again. So if you're interested, that's how you can get to it. And we have a team of researchers that are going to be participating. So if we can do it, anyone can do it. And if you want to join or you want to make a team, we'll help you do that too. You can even float. You don't have to even do swimming. So I co-direct with Levi Beverly, the Tumor Genesis and Therapeutic Outcomes Laboratory. And what our laboratory focuses on is we study mechanisms of tumor genesis and metastasis, as well as try to develop new treatments. But in doing so, we focus on the whole person. And we try to do so while eliminating off-target side effects, because the better we get at curing cancer, the more we need to be concerned with the short and long-term side effects from these treatments. And that's really what I'm going to be telling you about today. So I'm going to tell you about some background on cisplatin, how we study that and what we've learned from developing more clinically relevant models. And then a really important recent finding that my group is really focused on in the past few years, which is the comorbidity of cancer and why that is so important. And we're really actually focusing more on that than other things now. So why do we study cisplatin? It was approved in 1978. And when it was approved, it took the survival rate of testicular cancer from 10% to 85%. So it's a really effective chemotherapy. It's actually one of the most effective ones we have used for solid tumor cancers. The problem with it, the main dose limiting toxicity is its nephrotoxicity. There are other side effects, but they don't often limit its use. And it's in a class of chemotherapeutics that cause toxicity in 30% more of patients. And so these are some major drugs that we've all heard of, like gemcitabine, and gemcitabine is actually often combined with cisplatin. These drugs are now increasingly being combined as standard of care with the immune checkpoint inhibitors that are increasingly also being shown to cause side effects to the kidney like nephritis. So I think this is going to be a problem that's not going away anytime soon. We estimate that there's 15 million new cancer diagnoses per year. 1 in 5 of those are estimated worldwide to be put on cisplatin. And so if 30% of those people are getting kidney injury, that's about 900,000 people per year. So this is a significant medical problem. Even bigger, what we think is that people that suffer AKI or repeated AKI insults are much more likely to develop chronic kidney disease. And it's estimated from 10 all the way up to 30 times more likely to develop chronic kidney disease. And really the problem is, what do we do when patients have acute kidney injury? And we really do, the nephrologists in the room can tell you there's very little that can be done because we don't have any treatments that prevent this injury or right now improve the recovery from this injury. So the patient has to be taken off the chemotherapy, or it's delayed, or they're given a less nephrotoxic chemotherapy like carboplatin, but carboplatin for many forms of cancer is not as effective. Some of these patients can recover and continue treatment, but some do not. And I want to argue that a lot of the diagnoses of AKI is based on serum creatinine, and serum creatinine is a poor marker of kidney function because it really only changes, it doubles when there's a 50% loss of nephron function. So it's not a very sensitive marker, so people are looking for better markers. This is a study that came out of Memorial Sloan Kettering. And what this study did is it looked at all cancer patients that came in and received cisplatin, and it measured their estimated glomerular filtration rate at baseline after completing their cisplatin treatment at year 1 and year 5. And what I want to highlight here is the fact that there's a large percent of these patients that are already being diagnosed at CKD stage 2 before treatment. 11% of them are at CKD stage 3, and that triples after completing that cisplatin treatment, and that rate stays elevated even 1 in 5 years post-treatment. So this chronic kidney disease following cisplatin is a significant problem. In Kentucky, we really are in the perfect storm. Why? Because we're the highest cancer mortality rate for the entire US. And I think I'll show you in a minute, for lung cancer, we're #1 mortality rate, I think, in the world. And the other problem is we're ranked second to West Virginia in the highest rate of kidney disease mortality in the US as well. So this is a big, both of these issues are a problem in Kentucky. And we think these could be linked because the risk of AKI in all cancer patients for all forms of cancer and treatment in the first year is 18%, and it's 27% at year 5. So this is a big issue, and I think the combination of these two problems is a problem we need to start really focusing on. So what are we trying to do? The ideal situation would be that we would have a treatment that we could give these patients prophylactically to prevent injury without impacting the ability of their cancer treatments to reduce tumor burden, or that we could give it following treatment to prevent that progression to chronic kidney disease or development of chronic kidney disease. And right now, we don't have any of these treatments. Every drug for acute kidney injury has failed in phase 2 clinical trials. There have been a history of 1 or 2 drugs that have been approved, like amifostine, but that was taken off the market after it was, it was stopped being used after it was found to actually cause more injury than it was actually curing. So NIH has gotten, NIDDK has gotten really interested in trying to figure out why we are failing in clinical trials, and why, for example, the cancer field, as they call it, are succeeding, and they're calling that a success, but keep in mind that only 10% of the ones are succeeding in cancer. So we still need to improve there. And so they have had several conferences on this issue, and at one point, Dr. Levi Beverly and I attended because we were really interested in this problem and changing the model. And there's 3 things that are really a problem with acute kidney injury research. One is that it's hard to get renal biopsies because there's no potential treatment for the patient, unlike lupus nephritis, and Dawn Castor's here, she can tell you, where really the biopsy guides treatment in a lot of ways. So that the risk the benefit outweighs the risk. Well, here there's no benefit to the patient. So they're trying to get more research biopsies, but they are very hard to get a hold of. They're few and far between. We think part of it is that the markers of kidney function are subpar, and those markers are guiding the success and the outcomes of these clinical trials. So that is a big focus. And then our lab thought that the rodent models were part of the problem, because we're modeling it in rodents in a way that's convenient to us as humans, and not in a way that reflects how patients are treated in the clinic. And so that's when, about a year before I was recruited to UofL, that's when Dr. Beverly and I started working on this problem together, me as the kidney person and Dr. Beverly as the cancer biologist. And so the old model that was used prior to our working on this problem was that people would use a single high dose of cisplatin, They would give it to male mice that were 6 to 10 weeks of age. They didn't have cancer, so it was an acute injury. And these mice, if you didn't euthanize them, would die at about 4 days post-treatment. And this does not, thankfully, this is not what happens to people that get chemotherapy. We don't give them a dose that's going to cause them to go into complete failure and die. In the clinic, patients are given several low doses of cisplatin that are spaced apart to give the kidney a chance to recover before it's then hit with another chemotherapy. And so it's multiple rounds of therapy. People that get cancer and get cancer treatment have comorbidities. That 85% of cancer patients are over the age of 55. So they certainly have some comorbidities associated with not just their cancer, but they all have cancer. So we need a model with mice that have cancer, and I'll get to that in a minute. But it's a repeated injury and re-challenge model. And so that's the model we developed. I had a really brave graduate student back at the time, Sierra Sharp, who really was interested in developing this model and did so as her PhD dissertation work. And so she developed this model, and these are just two references of her work that characterize this model. And so, we were comparing this model, the acute old model to the new model. Okay, so in the acute model, we know there's a rapid decline in the glomerular filtration rate. There's a big spike in blood urea nitrogen, and there's big levels, there's throughout the kidney, there's levels of apoptosis and necrosis. And again, the mice not die within 3 or 4 days. In this new repeated dosing model that we developed, there's no really big, huge spike in BUN. There's a development of interstitial fibrosis. The mice can survive. We've aged them up to 6 months out. They probably could go longer if you want to pay for that. And there's a progressive loss of kidney function that occurs over time. And that's also characterized by chronic macrophage infiltration and persistence. And so this model has been adopted, and we've started to get at the mechanism. So I'm just going to show you summaries from 2 different papers here. This paper was in Kidney 360. It was the first author was Sophie Sears, a student of mine at the time, who's now actually junior faculty at the university here. And she, what she did was she was really interested in macrophages and the immune system and its role in this model. And so she wanted to look at the role of macrophages, both the resident macrophages in the kidney, but also the infiltrating. And so what she did was she took 2 approaches. One was cladrosome treatment. Cladrosome is a chemical and a liposome. The macrophages will engulf that and it will kill them. And then CCR2 knockout mice, they don't have the ability to infiltrate. So CCR2 is needed for infiltration. So what she did was she did the repeated low dose cisplatin treatment. She did flow cytometry on the single cell kidney suspensions. And when you did cladrosome, it depleted this F480 high resident macrophage population that were M2-like with cladrosome treatment. It did not impact, though, the infiltrating macrophages that are not phagocytic yet. So that makes sense. But what it did was it decreased collagen buildup in the kidney. It prevented the myofibroblast accumulation and proliferation, and it also blocked inflammation. When she used the CCR2 knockout, the infiltrating macrophages were blocked, but there was no change as expected in the resident macrophages, and this had no effect on kidney fibrosis development. So at least with repeated low-dose cisplatin, this suggested that it was these resident M2-like macrophages that were playing a role. Another study that Sophie did, it was known that autophagy played a role in the single high-dose model, and she was interested in what role does it play in the repeated low-dose model. And so she put autophagy inhibitors, either chloroquine or in parallel 3MA, into that old single high dose model versus the new repeated low dose model. So in the single high dose, when you give inhibitors of autophagy, you get an increase in BUN. So that would indicate that the single high dose, that autophagy is actually protective in this model, that it's protecting the damage. And if you eliminate autophagy, it makes the damage worse. Another group had also published this as well. So that's consistent with what's in the literature. When she put it into the repeated low dose model, what it did was it actually improved the fibrosis. It blocked any change in the kidney function induced by the cisplatin, and the fibrosis was improved. So you have a single target of autophagy, inhibitors of autophagy, in one model causing it to be worse, and in another model causing it to be improved, suggesting that these 2 models really are very different. The repeated low dose isn't just simply a low level of the high dose. It really is inducing a different biology. And this piece of work came out in parallel with a totally other group's piece of work from Augusta in another journal at the exact same time. And we got the same results, which I think is really awesome. And so many groups have studied this. I'm not going to go through all of these, but now this is being used around the world, and we've learned a lot of things. We've learned that this mechanism of injury has persistent inflammation and ER stress, that it really is a fibrotic-like disease. It's an interstitial fibrotic disease that involves cumulative DNA damage and failed repair of these tubules. People have done single cell RNA sequencing analysis to look at these changes. It can be protected through multiple mechanisms, such as inhibiting the inflammasome if you delete P53, but you'd never want to do this in a cancer patient because that would be very bad for the cancer. Inhibiting autophagy, reducing the M2 macrophages, or this kidney secreted renalase or renalase agonists are also protective. So we're learning a lot from this model. The problem is, this is a mouse model, and as people say, including Levi's famous for saying this, all models are crap, but some are informative. And so really, we aren't trying to cure nephrotoxicity in mice. We really care about humans. So what happens in humans is this same biology occurring in humans. And to be honest, we don't know. We don't have renal biopsies that we have access to at the moment. At least I don't. And so we turned to ask this question to the pig. When at the University of Louisville has a big pig research program here. And so there's a lot of expertise to do research in pigs. And the reason we turned to the pig is severalfold. One, out of all the vertebrates, even non-human primates don't have this pyramidal structure in their kidney, but pigs do, like humans do. So their kidney structure is very similar to humans. Most of the things that you can do in a mouse genetically, you can do it in a pig now. They have transgenic pig models. And they know that the kidney physiology is very similar to the human kidney physiology. Their body surface area is the same as a human, so the dosing is the same. You can treat a pig identically to a human. So they come with cancer, they come with ported, so you can actually administer chemotherapy intravenously and over the time that the human gets it. Because in a mouse, it's a single IP. And so really anything you can do to a human, you can do to a pig. And so myself, Levi Beverly, and Jeff Clark at one point had some pig research going on. We were trying to make a pig cancer model. We were not successful, but this just shows, and I had permission to take this picture, a pig that was put into the PET CT imager at the cancer center, the same one the humans go into. And again, so this kind of shows you anything you do to a human, you can do to a pig. And so we dosed these pigs with our repeated low dose model. And we used the model that was used for cisplatin in non-small cell lung cancer, which is 7 mg per meter squared. Given over a 2-hour period, we gave all the same medications that they give. And we had some age and sex matched Yucatan mini pigs that weren't dosed, given as gifts from another lab that wasn't using them as our controls. And so what we did was we dosed these pigs with cisplatin. And we then followed them out. When they got injury, we didn't euthanize, we just followed them out and full disclosure until COVID caused a shutdown, and then we had to terminate the experiment. So pigs are they're not genetically as identical as mice. So you're gonna get a lot more variability with pigs like you would humans. So in the first pig, it got a dose of cisplatin right here at day 0 and immediately got a spike in its serum creatinine and blood urea nitrogen. And that stayed elevated for the most part throughout the rest of the 24 weeks. Pig 2 got that dose and didn't have a change in their serum creatinine initially until the second dose given 4 weeks later when it spiked. And I think this is just variability in something we had no control over, but it stayed fairly elevated throughout the experiment. Mark Dahl, my lab manager, was able to measure NGAL, which is a sensitive marker of kidney injury in the urine of these pigs, and they do spike the NGAL shortly after dosing. And again, we have a lot of measurements on these and we have a lot of samples still. When we looked at fibrosis, this is serous red staining. So the red here is collagen staining, indicating fibrosis. The pigs that got cisplatin had increased collagen staining, as you would expect. and increased Mason trichrome staining, which is another marker of fibrosis. So now there's lots of models out there. We've got the single high dose. Another group uses 2 intermediate doses, so it actually injures and comes down and injures again, so you can study that downward recovery. Our repeated low dose model, and then this pig model. But what about the comorbidities? All patients receiving cisplatin have cancer, or they had cancer that was resected. And so we really thought that needed to be an important part of the model that was actually being ignored. And so one of the types of cancer that we study in our group is lung cancer. And the reason we study it is because it kills 2.5 times as many men as prostate cancer and 1.5 times as many women as breast cancer. So it takes more lives than the next 3 most common cancers combined. And again, Kentucky, unfortunately, has the highest incidence and the lowest survival rates for lung cancer. So it's a big area of research in the state. I'm just going to summarize some work that a previous student of mine, Andrew Orwick, did. This paper came out in 2023, and it actually got Paper of the Year award for American Journal of Physiology, Renal Physiology. And in this paper, what we did is we put lung cancer in this model. It had 3 different lung cancer models. One was a genetically engineered mouse model that you induced by putting them on doxycycline chow, and it would develop adenomas in the lung. The second was a syngeneic model, where it was a metastatic model, which was a KRAS mutant activating KRAS and deletion of P53. And the third was we put it in an immunocompromised mouse that didn't have B and T cells, but still did have macrophages. And in all of these, we found something very surprising, actually. What we found was that when you put cancer in the model, before you even treat with cisplatin, these mice had elevated BUN. They had elevated markers of kidney injury in their urine, like NGAL and KIM1. They developed interstitial fibrosis, and they had increased cytokines. And this was before cisplatin was even given. And then when you gave cisplatin, it made them much more sensitive to developing the chronic kidney disease. It was much worse. I'm just going to show you a little bit of data from this. This is one of the models we employed. The mice have what's called a lock-stop LOX G12D, so it's not active, and they have a P53 that's floxed, again, not active. This group, Monty Winslow out at Stanford, they give a lentivirus in the lungs that can turn on those things by giving a Cree recombinase. And so when they do that, they develop tumors in the lungs. Some of these tumors will metastasize and some will not. But that lentivirus integrates at a specific site in the genome. So they can track a metastatic cancer back to its primary tumor, and they can say, these primaries we could find any mets. And so we have these cell lines from this model. Some are metastatic and some are not as metastatic. And then we can put them back into that same mouse where it has an intact immune system. So when we did that, we had 4 groups. We had a group that just got vehicle controls, no cancer, no cisplatin. A group with no cancer that got cisplatin, a group that just got cancer and no cisplatin was vehicles, and a group that got both, cisplatin with cancer. And you can see here, the tumors do have an overall reduction in size following cisplatin treatment. And when Andrew looked at the blood urea nitrogen as a marker of kidney function, at urinary NGAL as a marker of kidney injury, and KIM1 as a marker of kidney injury, what he found was that there was some elevation in these markers in the cancer alone group, and it was further exacerbated with cancer and cisplatin than cisplatin alone. We looked at some fibrotic markers, and what I want you to focus on here is, here's our vehicle controls, and here's our cisplatin with no cancer. The cancer alone without cisplatin is inducing fibronectin accumulation, alpha smooth muscle actin accumulation, and TGF beta, which is another fibrotic marker, at the same level as the cisplatin does before you even give cisplatin. So cancer alone is doing something to the kidney. Here's the staining to show that. So you get this red accumulation in your cancer mice that don't have cisplatin, and it's much worse when you combine the cisplatin with this cancer. And again, he looked at this in 2 other cancer models and saw the same thing. That's well and good, great, you get fibrosis, but if it doesn't change the kidney function, who cares? So there's a new, not really new, it's new to us, way of measuring kidney function in live mice in real time. And it measures transdermal glomerular filtration rate. So you give these mice an injection of something. We use sinestrin. And then you put these units on their skin where you've removed the hair, and the units will trace the clearance of that substance because it's freely filtered by the kidney over time. And through mathematically modeling it, you can get your glomerular filtration rate. So here's some data that our lab has generated in this cancer model, looking at 7 days after the tumor implantation versus 24 days after the tumor implantation. And you can see a significant drop in glomerular filtration rate. And I just want to point out these mice have not had cisplatin, indicating that the cancer is impacting the kidney. Excuse me, I've got a tickle in my throat. We were able to use very sensitive droplet-based PCR methods to show that this cancer is not metastasizing to the kidney. So we're not getting any tumor DNA in the kidney. So it's not through a direct metastasis to the kidney. This is a paper that we're submitting that's been deposited at bioarchives. Here's the QR code if you're interested in looking at it. This is the first author here is my student Dana Hamori. She's also going to be giving a talk tomorrow on this and at ASN on this. And what the questions we were asking is, that's well and good. This was all the data I've showed you is with a specific lung cancer KRAS P53 deletion. Is this a general phenomenon in cancer that talks with the kidney, or is it more specific? And so what we did was we looked at other lung cancer lines, and some of these that were had more metastatic potential did cause fibrosis in the kidney. We looked at lung cancers that did not have a KRAS driving mutation. We looked at EGFR mutant lung cancers, and those also had fibrosis in the kidney. We've looked at non-lung cancer types. So we've done breast cancer, human and mouse, actually breast cancer xenografts. And those did cause fibrosis, whereas melanoma, the B16 melanoma does not, regardless of the tumor size, nor do some other more not as favorable lung carcinoma models. The LLC carcinoma didn't do it either. That's not a very good model anyway. So we know it's not because of metastasized to the kidney, but the question still remained on, and I'm going to show you a little bit of this data, and then I'm going to ask a question about whether it was because of a metastasis to another organ. So here's a little bit of data from this study where we put the different types of lung cancer in versus I'm going to show you the LLC model and the B16 model, and then looked at the kidneys. None of these mice have had cancer. Have had cisplatin, sorry. And when we did that, we found that, here you're looking at your tumor weight. So here's this B16. So it's a really large tumor. And despite its size, you'll see it doesn't really do anything to the kidney. The others do have somewhat of an increase in BUN, but remember, BUN is a really poor marker of kidney function in mice. You need a really big change to see it. So we do see changes at GFR at this stage where we don't see in BUN as much. It takes a little bit more to get that BUN to spike. You get really robust changes in urinary indel and in KIM1. If you look at these kidneys, you can see that there's fibrotic evidence on pathology of fibrosis of this collagen, this red collagen, but not for these two, we call them our control lines. So that's well and good, but this is a lung cancer model, and I told you it was metastatic. And we know from our looking at the lungs that we do get metastasis to the lung. And pulmonologists and nephrologists will tell you there is a big pulmonary renal crosstalk that occurs. In fact, it was a big problem, from what I understood, in COVID, where the lung damage could lead to kidney injury. And so the question we had is what we're simply seeing is metastasis to the lung, damage to the lung, and then that's why the kidney is getting fibrotic. So to answer this question, what we did was we used a subcutaneous model like before, where you inject it in the hind under the skin, versus a seeding model where you give the cancer cells through the tail vein. And then what they do is they then seed the lung and develop tumors in the lung. And we did that with a line that really causes a high level of fibrosis and compared it to a line that was non-metastatic that did not cause fibrosis. So here we're taking that non-metastatic line and we're putting it in the lungs. And then we're saying, now, do we then get fibrosis? And the answer, I'm going to give it away, is no. So here you can measure the amount of tumor in the lung by measuring the DNA, so your mutant KRAS, and you get a lot of cancer cells in that lung through that IV tail vein injection, as you would expect, regardless of whether they're metastatic or not. And if you look over here, you do get injury when you, with the line that causes fibrosis, you get an NGAL, you get a KIM1, you get some with the non-metastatic line. But when it comes to fibrosis, really with the serous red, it requires this metastatic line, this 2,3-1, whether you give it sub-Q or IV, it causes fibrosis. The non-metastatic or not as aggressive line does not cause fibrosis, regardless of whether you put it in the lung or you put it sub-Q. And so that would suggest it's not simply a lung kidney crosstalk that's going on. So this is well and good. How does this impact our model? You know, does this actually have cancer in the model? It's more difficult to put cancer in the model. I mean, it layers on a level of complexity. Does it impact outcomes of renoprotective agents? And I'm going to give away the answer by saying yes. We have 2 examples in my group where we had an agent that was very protective until we put it in a cancer model. Here's just one piece of that data done by, I'm showing it because it's a big deal in the kidney field right now. These drugs like empagliflozin and the flozins that target the sodium glucose cotransporter 2. It's the latest and greatest in the kidney field. They're looking at it in everything now because they're showing decreased nephropathy by a lot of diabetic nephropathy and type 2 diabetics. And the way that this drug works is that it inhibits the sodium glucose transporter 2 in the proximal tubule. This transporter is responsible for uptake of almost 90%, reabsorption of almost 90% of the glucose. So when you inhibit it, what these type 2 diabetic patients do is they pee off their glucose, and it helps with things like diabetic nephropathy. Ironically, it doesn't evidently lower the hemoglobin A1C all that well, but they do have really improved outcomes. And so now they're looking at it in everything in the kidney field. They're putting it now into the cisplatin model, and it was protective in this old cisplatin model. And so the question came from our collaborators at UCSD, what happens if you put it in your model? And so that's what Dee in our group did. She put it in this cancer model with repeated low dose cisplatin, and they got this was I think this was dapagliflozin. And what she did was she looked at tumor size, and it didn't really, the SGLT2 inhibitors with cisplatin didn't really impact the ability of cisplatin to reduce tumor burden. Gosh, I'm a mess here, sorry. But when she looked at the fibrosis, the mice that got the SGLT2 inhibitor that had cancer and got cisplatin, it actually made the fibrosis worse. It did not improve it. So it made it worse in these patients. I mean, in these mice, they're my patients. And one of the things that Dee found that she thought was really interesting was that in the mice with cancer, she saw a decrease in SGLT2 before even giving cisplatin as compared to mice without cancer. And that really was interesting. We didn't understand why the mice with cancer would have a decrease in this key transporter, but perhaps that's why our drug's not working, because we're losing the target. To answer this and to begin to understand what's going on in this mice, we used a new method, new to the University of Louisville. I think we're the only in the state that has this capability, and only a few nationwide that has this ability. And it's called imaging mass spec. It's a Hyperion. And essentially what you do is you take your kidney section, and we have antibodies. You can use, I think, up to 48 different antibodies for different targets that you've pre-validated. You can conjugate those antibodies with different metals, and then you can use time of flight mass cytometry to quantify those antibodies at the single cell level. And then through our buddies in bioinformatics, no pressure, we haven't gotten there yet. We're just going to show you pretty pictures, but they're not anywhere near as powerful as the bioinformatics analysis. You can then look at how all the different cells are changing relative to one another. So when you have an injured tubule, what is happening in that tubule and what cells are near it when it's changing? And that's what Dana Hamori did. She actually optimized this whole technique for our lab. We're the only lab using it in the kidney here. I think only one other lab in the world is using it for the kidney. And so what Dana did is I'm just showing you 4 different markers here. of the 48. Aquaporin, which is a marker for one of the transporters in the tubule. Sodium glucose transporter 2, which is a very specific segment of the proximal tubule. The sodium potassium ATPase, which is another key transporter. And this is a DNA stain to get your nuclei. And when Dana did this, and she compared a section that didn't have cancer to a section from a kidney of a mouse that did have cancer but did not ever get cisplatin, what she found was that they were losing their key transporters in their nephrons. Aquaporin, SGLT2, and sodium potassium ATPase are all being lost in the kidney. I'm not showing it here, but it looks like what's going on for this loss is a partial EMT, epithelial to mesenchymal transition, that in the tubules, when that occurs, it also is accompanied by transporter loss. So that's what we think is happening here. But we have to do more of that work with our collaborators here. So really what we're thinking about now is we're not just my group, but a lot of groups are starting to think of tumors as their own organs. And if you think about it, the tumor has many different cell types. People think when you put these cancer cells in and they form a tumor, it's all cancer cells. It's not. They have tumor-associated, cancer-associated fibroblasts that support them. There's all kinds of immune cell infiltration. There's endothelial cells. I mean, it's a whole bag of different cell types. And you can analyze the immune cells in these tumors using cytometry time of flight analysis, which is similar to Hyperion, but it requires the single cell suspension. And that's what we did. And when we analyzed these tumors using CyTOF, 19 different of the tumor, there are 19 different immune cells in that tumor, which is really showing how complex this tumor, which we now think of its own organ, is. I have this red box around our favorite of these immune cells. This is the M2 macrophage population. We know it's M2 because it's 206 positive. It has all the markers that one would have for an M2 tumor-associated macrophage. These are known to accumulate in lung tumors. This is not a novel finding. So a lot of groups have shown this specific macrophage population in tumors. And so what Dana got really interested in is, oh, what are these immune cells? All these immune cells, do we see them on a Hyperion? So she looked, and one of those markers on the Hyperion is CD45, and that's a pan-immune cell marker. So you can see we're losing things like aquaporin, sodium potassium ATPase. We need to get with a glomerular person, but it does look like we are also losing nephrin. But when we're losing these things, we're gaining in white all these immune cells in the kidney. And when Dana looks more close up at these cells, she also then looked and saw that they co-localized with F480, which is a marker of macrophages. Okay, so what you're looking at is an enlargement of what I just showed you. Here's no cancer, so you do see some immune cells as you'd expect in some macrophages. You do see some fibronectin, they need some. You really don't have any markers of the myofibroblasts, and you don't have any really injured tubules. The lung cancer mice that did not get cisplatin, they have a lot of CD45, so a lot of immune cells. Most of these are F480 positive, and they surround fibrotic foci. So there's these fibrotic foci that form. The fibrosis isn't uniform in the kidney. There's these foci, and these foci are surrounded by these macrophages, and these macrophages become alpha smooth muscle actin positive, which is really interesting. That's actually remnant of a transition that they can go through, and they surround the damaged tubules. And when you put cisplatin in here, and the beauty in this method is cisplatin is a metal. And so in this Hyperion method, you can quantify the cisplatin on a single cell level with the other 47 markers because it is a metal. It's just convenient that the drug we study has a metal in it. And so you can see this is the platinum accumulation. And again, it accumulates at really high levels surrounding these in areas that are surrounded by these macrophages that are alpha smooth muscle actin positive. It's worsening with the cisplatin. And here's your overlay. So this method, again, you can combine this method with CyTOF or with flow cytometry. And I'm just going to show you one of the measurements Dana did, where she looked at F480 positive cells on flow. And again, you are getting a significant accumulation of these as you're getting a decrease in the glomerular filtration rate. So we really think the macrophages have a potential role to mediate this kidney injury and fibrosis in this lung cancer crosstalk, as well as with cisplatin. And so we already showed that the macrophages, if you deplete them with cisplatin, it's protective. What about with cancer? What do we know here? And that's where Dana got really excited. And so we did this experiment where mice had cancer or no cancer as a control, and they were either given clodrazone, which again is going to deplete the phagocytic macrophages, or our control, which is encapsazone. And she dosed these cancer mice, there's no cisplatin here, 3 times a week for 28 days, or marked it. And what Dana found on flow cytometry was that you do get an accumulation of these CD11b F480 high, those are the resident macrophages, and those are depleted with clodronate. So it is depleting our resident macrophages to baseline. KIM1 levels at the expression, that's kidney injury marker 1, is also being depleted when you deplete our macrophages. And here you can see the staining of that. So you got an increase in your kidney injury marker through cancer, kidney crosstalk. It's the encapsazone has no effect, and that's being prevented in the clodrazone treated mice. The PAS staining, PAS stains this brush border, and you expect it to be very intense like this staining of the brush border, and you lose that in lung cancer mice somewhat. And again, it is partially prevented in this clodronate treated mice. You see the same with collagen. You get an increase, and you get a prevention in that increase when you deplete these resident M2-like macrophages. And again, this is collagen staining. You see the same pattern. So this really suggests in this cancer kidney crosstalk that these macrophages are playing a role in this, somewhat of a role here. And so some of the questions that she's going to be answering for her PhD work is what exactly are these macrophages? Clodrazone depletes macrophages, but it also depletes other cells like dendritic cells that do go up in this model. So we really need to be specific, and we're going to be getting transgenic mouse models to specifically deplete these M2 resident macrophages over other cell types to really dial in what is the cell type. And because we think that's very important, if we know the specific cell type, then we could, with all the cancer immunology work going on at the Cancer Center, potentially target something that would be good for the cancer and also shield the kidney while fighting the cancer. So what's my take-home message? My take-home message is the model really matters. And I think we need to do the best we can when we're trying to get mechanistic and we are relying on animal models to develop models that best recapitulate as best we can what we see in the clinic, so that we can, until we get more research biopsies, we can really learn what's going on and then compare them. Right now, we can only compare them to serum and urine markers. But we have to have cancer in the model. And I think for the most part, we're going to be doing all our work now with cancer in the model. And so with that, I've got to do my acknowledgements, and this was sadly taken a year ago, and I happen to be wearing the same thing as today. This is, I've got to acknowledge the people that did the work. This is really some very talented graduate students and lab manager and lab technician, the people in Dr. Beverly's lab, all the really talented previous graduate students that really made it easy and a pleasure to come to work every day. The animal care staff, huge part of this work, our current and previous funding, and then our collaborators both at the UofL, University California, San Diego, and Stony Brook University for working with us. And then here's my shameless plug again to get, because we want this group to come back to Louisville. So with that, I'd love some questions.
Since diagnostic imager and CT was always shield the kidney while you're fighting the cancer, now it's and you're saying shield the kidney while fighting the cancer, but it's also shield the kidney from the cancer.
That's what we think.
This is really a novel concept that most of us were not aware of, and so this is like on its way to, you know, standard. I mean, we've got to come up with some answers, and probably some Nobel Prize in there or something like that.
Well, and you know, the onconephrology is becoming its own field, and we actually have an onconephrologist in the division of nephrology here at UofL. So we're eager to work with her. The issue is it's so hard to parse out the clinical data because cancer is a disease of aging, and as we age, there's an increased rate of chronic kidney disease. So separating that out from the actual cause of the cancer or chronic kidney disease to all the other causes of chronic kidney disease to really show that this is a direct effect of cancer causing chronic kidney disease in these cancer patients. And that's, I think we really need to get creative in our clinical analyses to try to do that with the clinical data. So hopefully we can get creative and find a way to do that in patients too, so that we could diagnose it. Like, so this patient is already having this fibrosis in their kidney and this crosstalk. So really putting cisplatin in this patient would be a very bad idea. So, you know, because other markers, they look like they could handle it. So.
Right. Well, I mean, open it up for other people, but I still wonder if there's something that we should be doing that, you know, is their diet is just because.
Yeah.
Follow for our other
Yeah.
conversation, everybody else wasn't part of the kidney stuff. I think Dr. Ree from UCSD presented last year that animal protein, all this massive amount of literature that is toxic to kidneys, and you can make them better with plant-based protein. Wondering if there are dietary interventions that we should automatically be doing if someone has cancer or they're about to get cisplatin.
Yeah, and I think that would be, I think we need to do that. And I think NCI is increasingly recognizing this because there's an request for applications looking at how diet impacts lipids and then how that impacts cancer. And I'd like to add also cancer treatment. And so putting something like the Americanized, not just high fat, but the Americanized diet, which would be the hypertension on board as well from the high salt and then the high sugar and high fat. That would be something I know that my student D she's itching to do. So yeah, I think that would be something to really look at.
Another clinical trial with nutrition intervention. All right. So questions?
Very elaborative and excellent work. I did some work recently on cancer-induced kidney damage. I expected that cisplatin, since it's suppressing the tumor growth, so it may help to revert the damage caused by cancer by cisplatin. But it looks like it's adding up the damage.
Yep.
So in our experiment, which I submitted the paper yesterday, we are using midopyrin A. It's really reverse what is damage caused by cancer. All the inflammatory cytokine was targeted, and inflammasome were down-regulated by midopyrin. So we really see almost 90 to 95% reversal of damage. That's what Dr. Williams is talking.
An improvement?
Maybe we should go for that kind of combination.
Is there an
Treat the
improvement of
patient
function?
with
I couldn't hear you when you said you just measured something today or yesterday. Was it function you measured, kidney function?
We didn't measure kidney function. We looked at creatinine as well as some of the inflammatory marker directly
Gotcha.
into kidney tissue,
Okay,
inflammasome, and some other genes we looked, and those were all elevated in cancer model. But when we treat with midopyrin A, they were all normalized. So, and creatinine was normalized to the normal circulation level. So it looks like it has a reverse effect, what you are seeing with cisplatin. So
I
that
think it
may
would be,
something-
yeah, I think measuring actual function would be good because we've seen things that look like they're impacting all those measurements that are down and then GFR is not improved. And I think that's the gold standard. So it'd be great. I think you guys have the GFR units in physiology, I know over there, because you had them way before we did. So it'd be awesome if you could look at that as well. Yeah, and then layering the cisplatin. I think with interferon A, there's some data, right, with cisplatin already.
I had a use combination therapy.
Yeah.
Tumor model.
Yeah, you
in
should
mice,
be.
and it really is neutralizing the effect of cisplatin.
Yeah, so it would
So
be
it
good to
really has
combine.
synergistic effect.
Yeah. Yep.
That could be something we can look at and go for a trial in fact.
Yeah.
What's the signal in the kidney that causes the macrophage infiltration?
It's a great question. That is really what we're after. And I don't think it's just causing infiltration. I think it's causing the resident macrophages to proliferate and then transition from an M1 to M2. We don't know what type of M2, because there's, as you probably know, so many subtypes. And we don't know why they're not being cleared, because M2s are supposed to actually clear damage, and it looks like they're contributing to damage. So some data I'm not showing. It looks like in the cancer, it's a lot more complicated, that it's not just resident macrophages, but there is another pathology that we see in the kidney that's not being protected when you deplete the residents. And we're not depleting infiltrating, and we're actually getting more infiltrating when we deplete that. So we think we have to deplete both to really get at both biologies being changed, because it's not just the fibrosis, it's also preserving those, the tubular transporters, really getting those preserved. Because if you block the fibrosis, but you're still losing transporters, you're still having maybe a further effect downstream on kidney function. So it is very complex and we don't know. We don't know what's doing that, and we don't know what's coming from the cancer either. So we don't know what the cancer is secreting to cause the kidney to go through these changes, and that's a big thing we need to get at. But finding the money to ask that question is the hard part.
Yeah, so the expression, the transporter expression is just seems so much more like uniform across the kidney from what you were showing, and you alluded to EMT, or,
Yeah.
that's some dedifferentiation, perhaps playing a role in there. And I know you were showing also alpha smog going up, around the foci and potentially with the F480 positive cells. But like at a cell to cell level, like if you really get closer in the analysis, do you see markers of dedifferentiation? Because I mean, it's
Don't
pretty
know.
uniform.
So when we
The
do,
transporter's going down.
we do have a couple on our panel and we do see changes in them. And then I think the bioinformatics where we really need to dial in on, these are them, because we have markers of certain parts of it, as you know, of all people, I'm not telling you, I'm telling the rest of the people, that there are markers in this panel of certain segments of the nephron. And so really looking at when the segment that loses, that's normally aquaporin 1 high, when it loses that and becomes low, what is happening with the EMT markers in that segment? And then what's happening around it? Is it surrounded by macrophages? Because my hypothesis is that it's a crosstalk between these transporters that are losing these tubules and the macrophages. So I think that they are causing a positive feedback loop. Because some of our interventions have taken out one arm and it has not impacted the other arm. And so we get a partial protection. And I think, again, you have to do both. I think it's really important to look at what's changing in those tubules. And that's why the bioinformatics people are really the key to all of this. And we haven't started that work because it's actually really tough, from what I understand, to do bioinformatics, not just with 48 markers XY, but also neighborhoods and how those neighborhoods change. Yeah.
One more question, clinically, the relationship between lung cancer and kidney function?
There is a lot of actually good clinical data to suggest that the kidney disease incidence in cancer is the worst in the KRAS non-small cell lung cancer population. So there's a couple papers that suggest that that is one of the biggest populations in cancer that's impacted, that has a decreased kidney function. I think we need to figure out the biomarker side too, because then if you dial into the electronic medical records, what do we look for? Yeah. Because again, you can't really even do a trial until you know what to look for. Because serum creatinine, most of these trials fail because they depend on serum creatinine, and that's not going to be that improved if it's, so much to get a doubling, and it's really as an endpoint. That's why getting trials funded is so hard.
Since you mentioned bioinformatics several times, so are
I'm
you
selling it to you.
yeah.
To give
So,
yourself to this.
are you planning to do? I mean, I think getting the overall gene profile of each mouse model, it's gonna help you tremendously. Because if you think it might be from EMT, you can easily check the epithelial or mesenchymal specific genes expression level. And then you can find like an upstream regulator or downstream regulator and so on, pathways and so on. So I'm just wondering if you're planning to do.
Single cell RNA sequencing was done with the repeated dosing model. It's not been done with cancer kidney crosstalk. That would be great to do. We just have to get the funding to do it. The other issue that I have with it is that you're looking at a very small number of cells from that kidney. And so it's really a biased representation. And then data from Catalin Sustak is showing that really a lot of these message changes don't translate into protein. And so I think that's why the Hyperion is a better method, because it really is more dependent upon the protein, actual protein levels. A lot of the EMT markers, from what I understand, are hard to pick up as a message level. It's much easier to pick it up as a protein level change. So yeah, I think those would be helpful. I think though, but we can't fully rely on single cell RNA sequencing.
Right. I think in the bulk RNA-seq is probably better.
Or even laser capture might be good, because then we could, like, in a given section, through the Hyperion say, you know, or, you know, because we have serial sections, we can say this section is having these tubules that are changing in all these ways. And this section over here doesn't, and then use the serial section to do laser capture for RNA-seq on that section versus this section. So yeah, that would be ideal. And I think we're gonna have to team up to get some preliminary data to then write the grant to do all that. That is key, yeah. To show we can start doing it and then propose to really do it.
Yeah, that would be exciting. Yeah, just a quick question. Have you guys considered using Cisplatin-C as a measure of kidney function in cystic
Yeah,
fibrosis?
there's actually a fair bit of data where people have looked at that and whether that's a better marker in for this form of kidney injury. And I think the data, some studies show that it is, and some studies show that it's not a good marker. So, but that's a great, I mean, that's one of the ideas we had, because it is, a lot of the clinicians measure it, so, yeah. The pediatric, I think data is showing that it's not a good marker, and the pediatric is really a big area of focus because cisplatin causes ototoxicity, and during those critical years of language development, they lose hearing. And there is an FDA approved drug that I think has just gained approval that actually acts to prevent that loss of hearing, and it acts through the macrophages. So it'd be interesting to see what it's doing with the kidney.
But there's no question, I can ask another question. We know angiotensin II level in circulation go up patient in cancer, with cancer patient. As well as we have seen in the mouse model, when we generate tumor, the angiotensin II level go up very significantly. And angiotensin II is one of the major factor which cause damage to the kidney. What for cisplatin, does it increase or decrease?
We've
or
never looked at it.
Look at it.
Yeah,
I think that may be something to look at it, because it's a different effect than what I'm seeing with my drug. So,
yeah, that's a good suggestion. It's definitely something that we have thought about because of the lung too, with the renin-angiotensin.
since you have plasma or blood, you can easily look for it.
That's right, yeah. Especially we should look in the pig samples, in the cisplatin in the pig.
Thank you.
Do we know anything about cisplatin use and increased risk of infection?
So I know it does cause compromised immune system with regards to infection, fighting off infection, but that is the extent of my knowledge with that. Yeah, but I think that's pretty standard for a lot of chemotherapeutics. I don't know that it's because it causes neutropenia. I don't know. I don't remember what happened in the pig, whether we looked at whether that was going on it, because we did do the immune analysis of the pig kidneys and their blood. I have to go back and see what it was doing in the pig. Yeah, can't remember.
Fantastic. Thank you so much.